Okay, well, we'll get started. I'd like to welcome everybody to today's webinar. I am your co-hostess with the mostest, Amy Liebman, President of NTM and Bronchiectasis Research, along with Mary Kitlowski from Running on Air. We are very pleased to present today's webinar, Living Well with NTM and Bronchiectasis, Airway Clearance and More. We're very pleased to welcome our speakers from Yale University School of Medicine. Thank you so much for joining us today. And this is the one part that always trips me up, is advancing the slides. Here we are. I'd also like to give special thanks to Debbie Brzlowski, our NTM support group leader and our support group liaison, and to Dr. Lozier from Yale University School of Medicine, who helped organize this entire thing. I'm going to introduce our speakers now. First up is Marjorie Cullinan. She is the operations manager in the Department of Respiratory Care at Yale New Haven Hospital, where she oversees the pulmonary function labs. This is a lot. Exercise testing and outpatient respiratory care. So she's not busy at all. A registered respiratory therapist with a specialty in neonatal and pediatric respiratory care, Marjorie also serves as a consultant to the National Board of Respiratory Care. With more than 13 years of experience in outpatient cystic fibrosis management and specialized training in airway clearance techniques from the CF Foundation, Marjorie brings deep expertise in breathing techniques, airway clearance, and the role of exercise in respiratory health. Her professional interests also include sputum induction, pulmonary function, and exercise testing. Next up will be Dr. Sebastian Kurtz. Dr. Kurtz is a member of the Advanced Airways Disease Program and the current director of the COPD Clinic. He obtained his MD and PhD in microbiology from Julius Maximilians University in Würzburg, Germany. He underwent residency training at CWRU Cleveland, where he also completed a fellowship in pulmonary and critical care medicine. He has a focus on complex structural lung disease, inflammatory airways disease, and lung infections, with clinical experience in mycobacterial lung disease, including tuberculosis, NTM and bronchiectasis, complex pleuropulmonary and airway infections. His research focuses on identification of novel antibiotic combinations to treat resistant mycobacteria. He is board certified in pulmonary and critical care medicine. He is a fellow of the American College of Chest Physicians and a member of the American Thoracic Society and European Respiratory Society. And then bringing up the home lab is Dr. Ashley Lozier. She is originally from Canada, like me. She completed her undergraduate studies in biology at the University of New Brunswick in Fredericton. She then attended medical school at Saba University in the Netherlands, a residency in internal medicine at Norwalk Hospital in Connecticut, and a fellowship in pulmonary and critical care medicine at Yale University. Dr. Lozier stayed on as faculty at Yale and is an assistant professor as well as the assistant program director of the Pulmonary and Critical Care Fellowship, with a clinical focus on bronchiectasis and chronic pulmonary infections such as NTM and pulmonary disease. So welcome all you three, and we look forward to hearing from you shortly. So for today's webinar, there is a Q&A button. It's depending on what device you're using. It'll be at the top or the bottom of your screen. You can type your question in, and then you can hit send. If you want to send it anonymously, you just check send anonymously. I would like to state that we have 800 people plus registered for today's webinar. So there's a very good chance we will not get to all your questions today. We will try our hardest. We are going to keep the questions focused on the subjects of today's webinar. If there is a subject that you might ask about, if we have another webinar that we've already completed and there's a video available, we'll direct you to that. I also want to remind everybody that they are doctors, but they cannot diagnose you and they cannot recommend specific treatment protocols for you. So please keep your questions general so that everybody gets the benefit of the answer. Don't forget to follow us on social media. We will be making regular announcements about upcoming conferences, webinars, meetings, support group meetings, etc. So please make sure you follow us on social media. We'd like to thank our global sponsors for World NTM Awareness. We cannot bring programming like this to you without the support of our sponsors, so we're very grateful for that. I'm going to hand it over to Mary now for a couple of quick announcements.
All right. Thank you, Amy. All right. So thank you, and thank you for being with us today. If you're not familiar with Running on Air, we are a nonprofit, and our mission is to help others breathe more easily. And we focus on supplemental oxygen, but we also do bronchiectasis and webinars throughout the year. and we partnered on quite a few of those with NTMIR. You can follow us on our social media. The links, names are over on the right. One of the things we put out is a portable oxygen concentrator comparison chart. For those of you that do use supplemental oxygen, there's a lot of confusion on what machines are out there and how much oxygen they're capable of giving and that sort of thing. So we started producing this chart a few years ago of FDA approved POCs just to help you be able to better compare things and talk to your doctor or respiratory therapist to get the device that's right for you. As I mentioned, we do webinars throughout the year, and we have a couple scheduled October 13th. We're going to have an ERS conference highlights, and on the 29th of October, PCD on the move. But these are other ones that are coming. We also have a newsletter if you're interested in registering for either of the webinars that we do have up and running already, or joining our newsletter so you can keep up to date on future webinars and other important information on bronchiectasis, NTM, and general lung disease and research. You can use these QR codes. Thank you, Amy.
Thank you very much. And I'm going to turn it over to Debbie Brzezlowski now, so she can say a few words before we get started. Debbie, thank you and welcome.
Thank you, and thank you all for attending this. If life takes funny twists and turns, so I am a patient, a bronchiectasis and NTM patient, and when I started going to Yale for my care, I happened to mention the webinars that I was involved in with other organizations, and my doctor said, "Oh my gosh, we would love to do something like that too." And that goes back probably at least 10, 15 years ago. And we started out in person. This is before Zoom. We started out in person at Yale. We were invited, the New York support group and the Connecticut support group, and we probably averaged 25 to 30 people. And then Zoom happened, and here we are with hundreds of people, and we are so grateful that we have this opportunity to bring this to you. So I just wanted to share that with you because that's the history of how this got started. And you never know, and when you're speaking to your doctor might say to you, "Gee, I'd love to do a webinar." And if that's the case, let us know. Thank you. Amy?
Yeah, sorry.
That's okay.
Yeah, my excuse is that my nephew's not here to show me how to use this. Thank you very much, Debbie. We'd like to thank everybody for coming today. We have several hundred people already online and more joining still. But we're going to kick it off now with Marjorie. So Marjorie, welcome. You should be able to share your screen and share slides. And
All right.
okay, great. We're turning it over to you now.
All right. So thank you all for inviting me back. This really is a highlight of my year, to get to talk to all of you. As an RT and as an operations manager, I don't always get the chance to see every patient in a clinic, and there's a lot of principles of airway clearance that I'm very passionate about, and so this really helps me to be able to speak to as many people as possible and get the word out about airway clearance. Airway clearance is therapies, all sorts of different things that your doctor may recommend for your care. So we're going to be talking about all those different options today, and then I do have some little what's new kind of opportunities, but we're just going to kind of kick it off. So I just want to give a disclaimer, just as I said before, I am a respiratory therapist. I'm not your provider or pulmonologist. So your provider may make some recommendations for you that I don't include in this presentation today, or may go against something that your provider has either recommended or said something that you should not be doing. These are general recommendations based on evidence. and general patient care. But my mission always is to arm you with information so that you can go back to your provider and say, hey, this may be something I want to try. This is something that's worked for someone else, and give you the right resources to be able to take care of yourself, because unfortunately, airway clearance isn't one of those things that we can just wave our magic wand and make you better. It's something that requires your effort every single day, so that you can feel better and that you can live the life that you want to live. So, the cycle of mucus and mucus development and lung infection, it is a vicious cycle. You probably came to care when you were symptomatic, whether it was with an infection or just increased amounts of mucus, but your body does this whole process of when a bacteria sets into your lungs, it makes mucus to try to fight it. When it makes mucus, then you end up with inflammation. Inflammation can make your lung infection worse. But really, in the process of airway clearance, what we're trying to do is to break that cycle. So there's a lot of different things that are medically available to treat things like lung infection and bronchiectasis, but airway clearance is something that is a regular intervention that you may do a couple of times a day, up to many times a day, depending upon where you are, in this cycle and how you're feeling that day. Remember also that we live in a world that is not in a bubble, and we get exposed to things, and we get exposed to viruses that are out there. 'Tis the season. We're about to head into flu season. Airway clearance is an incredible tool to help you to get better in the season where you're being exposed to more. So something that people will come to me and say, I heard that there is this regimen, there is this thing that works for this person. And why doesn't my doctor recommend that for me? Airway clearance really is about personalization. There is not a one size fits all. There is not something that is necessarily a slam dunk all the time for you. If there was, we would be right here saying, this is the thing, everybody do the thing, and you will get better. But it really is about finding what works for you, also finding when it works for you, and having plans for when you're sick, when you're well, when you're traveling, so that airway clearance is something that is consistent across the board to help you to feel better, and also to realize that life happens and we get busy, but we don't want to get sick just because we got busy and we're able to do things to help keep us healthy. Also, I like to say that airway clearance is more art than science. So there is not a tremendous amount of literature out there to say that there are certain methods that are better than the rest. The most important thing that we have found in airway clearance is that consistency is key. And finding what is out there that can help you to be consistent and to customize a program for you that works is better than just throwing the kitchen sink at you, putting all the technology and all the medications out there, overwhelming you and making it so that it's something that you can't accomplish in your everyday life. So in airway clearance today, we're going to talk about a bunch of things. We're going to talk about positioning, what is optimal positioning for you when it comes to doing your airway clearance, the inhaled medications that are out there, and also the order in which they can be done to be the most effective, the different percussive modalities that are out there to help you to mobilize mucus, whether it's inside the chest or from the outside of the chest, and as Debbie knows, my favorite is breathing techniques. So things that will help you get air behind the mucus to get it up and out. And let me just give my first plug for breathing techniques that you need no equipment at all and don't need to be anywhere in particular to do breathing techniques. You have your lungs everywhere you go. So I like to start with this analogy of the peanut butter jar because I have a 6 and 8-year-old and we go through peanut butter jars on a regular basis. And they are particularly difficult to clean. So how do you clean a peanut butter jar? So first you fill it with water to soften or thin the peanut butter so that it's easier to get off the walls of the jar. Then you can do something like you can shake the jar to loosen it, or you can use something to scrub it out to make sure the peanut butter gets off, because we're all going to recycle and be good citizens and put that in the recycling instead of the trash. So we want it nice and clean. But in the end, even though we put water in there and we shook it and we loosened, we're eventually going to need to scrub the inside of the jar and completely remove all of it in order for it to be a nice and clean jar. So taking that peanut butter jar analogy and applying it to the lungs, in airway clearance, we can nebulize medications to open the airways and thin mucus. We can then use things like our percussive modalities, like our acapellas, aerobicas, or vests, to shake the mucus free from the airways. But you need to take the time, even though you did those things, you need to take the time to actively participate in breathing and coughing techniques to be able to effectively clear mucus so that your lungs can get better and so that you can feel better. So, positioning. This is something that is a lot of folks think of as a new topic, but it actually has been very historically relevant. When we think about how we breathe, and if you ever come to my PFT lab, I'm going to make you sit with your 2 feet on the ground and your shoulders back. And the reason that good posture is important is because our lungs were actually made to function in an upright person. So when we sit, we have the top bits of our lungs and the bottom bits, and we want to expand all of it. Just to give you a little bit of science behind how air moves in our lungs, the air that we breathe is actually mostly nitrogen. It's about 79% nitrogen. 21% of what we breathe in the regular air is oxygen. Oxygen is a heavier molecule than nitrogen. So oxygen tends to go to the lower lobes of the lungs, and nitrogen goes to the upper lobes of the lungs. The genius design of our lungs are that they're smaller on the top and bigger on the bottom. So the oxygen going to the bottom of the lungs is the most efficient way to absorb the oxygen. Depending upon where your airway disease is, that can affect the way that oxygen and nitrogen move in your lungs. And there's a lot of lung disease found in the upper lobes of the lungs because nitrogen does not absorb into the lungs and does not go into your blood. So it's easier for air to trap in the upper parts of the lungs than the lower. But we're going to use the same principles of heavy things go low and lighter things go high. Mucus and infection can find itself into any part of the lungs. And the more mucus you have, that heavy stuff can kind of go down to the lower bits of the lungs. So we want to be conscious in our airway clearance that we're addressing where the mucus is. And that is an amazing question to ask your provider. They do imaging like chest x-rays and CAT scans. And you can say, hey, where is all my mucus? And can I help with positioning to target that more directly? Historically, postural drainage was a way that we tried to get fluids out of the lungs, in particular in the era of tuberculosis, where it was really rampant. Doctors used to put their patients almost all the way upside down to drain the phlegm out. And actually, it was a bit ingenious in that wherever that infection was is in a part of the lung that needs to move out. Think of your lungs like a tree. The branches get smaller and smaller as they go out. If you have a bit of a branch with an infection, put it at the highest point on your body and let it drain into the larger branches so it's easier to get that mucus up and out. In the hospital, we do this all the time, where if someone has a lung infection, and in particular, we're having trouble getting oxygen into the patient, we always put the bad lung up and the good lung down. The good lung being down gets all the good oxygen. The bad lung is up and we can drain the bad stuff out of there. So that's where postural drainage really comes from. Also, in the cystic fibrosis community, we had been doing chest physiotherapy as a way to drain mucus from their airways. And this goes as far as back as parents clapping on the chests of their children to get mucus out. And these are before things like vest therapy. And also in the hospital, chest physiotherapy has existed sort of for a very long time. What we do is we put the part of the lung that has the infection up, we clap on it, and we let it drain out so that the patient can cough things up. These are various positions that the chest physiotherapy and that postural drainage used to happen in. And these are things that you can easily accomplish laying on your bed or laying on a couch. Sometimes a little bit of a wedge is helpful just to sort of get your lungs lower than your hips. So this has all existed for a long time, but in more like a hospital setting. The only thing that we really want to recommend that when it comes to NTM in particular, sometimes downward facing positions can cause more reflux. So you just want to be mindful when you do lay down that you are, if you do have reflux, that you're following your doctor or recommended recommendations. And you're also mindful, am I feeling like I have more reflux right now as I'm laying down? But you know me, and I love exercise. So there's ways to accomplish postural drainage in regular exercise. Yoga is a great one. Downward facing dog is a very anatomically correct position. And you can actually do things like a cappella and aerobica with yoga positions. Also in yoga positions, we're concentrating on breathing, which I love so much. But you are draining the lungs in that fashion. I was a swimmer. Swimming is a great way. As you rotate under the water, air gets redistributed and goes to the highest point of your lungs. It is helpful in getting air behind secretions and draining mucus out. There's also inversion tables. I'm not a huge fan. I'm somebody who suffers with headaches, so an inversion table would not be something I'm going for. But there are people who do find it helpful in draining mucus, and it has inversion tables themselves are made to be safe for you. So it is a safer way of doing some postural drainage. And then always remember to do deep breaths and things like huff coughs that we'll be talking about, because while we're going to be shaking up the jar, we need to get that air behind mucus so that our time and effort spent in the postural drainage positions are effective. Inhaled medication therapy. I think this is something that I could go to every single doctor's office and stand upon my soapbox and talk about order of inhaled medications, because it is important. When your doctors prescribe you medications, there is an order in which it is more effective to be able to get air behind secretions and to be able to loosen mucus. So there are several medications that can be recommended for a patient with NTM, starting off with some bronchodilators. Those help to open the airways. It depends on how you tolerate them and if you feel like you need them. And if you do have any history of bronchospasm or asthma or things that have already irritated your airways, your doctors may recommend these types of medications. But they're really just opening things up. Osmotic agents are your salines. There's 3% and 7% saline. That's just salty and saltier. They help to add some hydration to the mucus so that it's easier to mobilize and to get up, especially if it's very thick and sitting on your airway walls. Osmotic agents are very helpful, and they're also very natural. We live in a world in which salt is a part of us. We are from the ocean. If you've ever been out, that I do love going by when you're on a boat or by the ocean, you do notice a little bit more of that hydration and ability to deep breathe. And saline can provide that to you in your home. Long-acting bronchodilators and inhaled steroids, these are very personalized by what your doctor feels like you need to keep your airways relaxed and keep them from having inflammation. But this is really something that on a case-by-case basis, your doctor will recommend for you based on your pulmonary function tests and how you're feeling. Inhaled antibiotics. So there are medications that you can inhale. You don't need to take to your whole body. Things like tobramycin. It is one used for Pseudomonas, which is oftentimes lives side by side with NTM. These are given in special nebulizers and can be very important to eradicate or to keep the amount of Pseudomonas in your lungs at bay. But as I said, the order is important because of the principle behind it. So the things that help to bring up mucus are our bronchodilator by opening and relaxing the airways, especially with a chronic cough. You want to make sure your airways are as open as possible before you start your airway clearance. Your osmotic agents are going to be what hydrates the mucus to make it thinner so you're able to bring it up. Both of these two classes of medications can be done before airway clearance and also during airway clearance. And that could be something that you kind of work towards, where you come up with a customized plan with your provider for how you're going to take these medications. Many people, if they're using vest therapy, they do their medications while they're on their vest. You could do them before you do other forms of airway clearance like acapella and aerobica. And also these medications are approved for the positive airway pressure modalities of things like Volara and byways that we'll be talking about a little bit later on. Once you have cleared the immediate mucus that you have, so whatever it is that's kind of brewing in there, whether it's morning or evening, and you've mobilized what you feel is the mucus that's bugging you, then you're going to take your longer acting medications. The reason that you're going to take those after your airway clearance is because you want those medications to stay in your lungs, and you want them working from the end of your airway clearance all the way until you do your next airway clearance. So things like long-acting bronchodilators, your inhaled steroids to decrease inflammation, and your inhaled antibiotics. Something that does happen as people are customizing their care is sometimes we make this to-do list or a checklist where we take all of our medication, then we do all of our airway clearance, and then we move on. Something that can be a beginner's mistake in taking all your medications at once is that if you take your long-acting inhaled medications and then do airway clearance and cough, you're coughing up your long-acting medications. You want those in there. You want those working throughout the day when you're not doing airway clearance, when you're just living your normal life. You do not want to cough up the important stuff that's going to be acting throughout the day, over the night, to help you to feel better. So one of my favorite things is a huff cough. So we're going to talk about breathing techniques now. But foundationally, huff cough, it's in every good airway cycle of breathing. And what it has is three principles. You're going to take a deep breath in to fill your lungs full of air and give you more power. You're going to hold your breath for 3 seconds, and that's to recruit as much airway and as much power as you can. Then you're going to do a long exhalation until you don't have any more air left. And that is because you are going to push every last little bit of air out of all the little pockets of your lungs so that mucus can be moved out of them. What's nice about a huff cough is that it is a controlled breath. It does not send you into coughing spasms. And it also is a maneuver that's done with a nice open airway so that mucus can pass through that airway. When we cough, we have been doing that since we were babies. We were never taught how to cough. But something that physiologically happens is that our airway closes when we cough. We cough, 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 cough. And we're closing the door for mucus to come up, especially if it's really thick or there's a lot of it. So a huff allows it to move through an open door out of our airways and in a way that is not irritating to the airway itself. So it's a deep breath in, hold for 3 seconds, and a long exhalation until we're totally empty. It's a good thing to practice on its own and to do in cycles of about 3 breaths at a time until we get really confident with it. But this principle of huff cough follows us through other breathing techniques. And then also when you use your oscillatory PEP devices like acapella and aerobica, same maneuver, we're just adding percussion to it. When you come for your pulmonary function test, we often see when you exhale completely for our test, when we push you to the point where you think that we're absolutely nuts and there's no more flow coming out, we always notice that people are a little bit more productive of sputum. So please push to that long exhalation to get as much as you can out of your huff cough. So as I said, anatomically, you're going to have nice open vocal cords. You're going to be sitting up using your proper posture. You're going to do your deep breath in and then all the way out with a nice relaxed throat. The next breathing maneuver is active cycle breathing. Whenever I do these talks, everybody always asks me what's new. I'm bringing back something that is very old and bringing it back to the table as active cycle breathing is a technique that takes time. It takes a little bit of effort, but it has always been effective. So you can start active cycle breathing at any point in this cycle because you see it just goes back and forth. But I'm going to start with some deep breathing. So it's 3 to 4 cycles of deep breathing all the way in with a hold, all the way out, 3 to 4 breaths. Then purse lip breathing. If any of you have done pulmonary rehab, you're going to breathe in, smell the roses, and then you're going to blow out against pursed lips, blow out the candles. And what you're doing is you are recruiting your lungs, just as you did in your huff cough breaths, to try to get air behind mucus. So deep breathing, pursed lip breathing, deep breathing, pursed lip breathing, and then your huffs to finish. You can do this in 3 to 4 cycles. You can do this absolutely anywhere, and you are going to get air behind mucus and be more efficient to get things out. So your deep breathing is going to give you that total lung capacity and power. The pursed lip breathing, by breathing in through your nose and out through those lips, puts positive pressure back in the lungs to give you volume and stamina to be able to complete the full cycle. And then you have your huff coughs to open your airways and to clear mucus at the end. I will be sharing my slides, and if you look up active cycle breathing on the internet, looking at that cycle is very, very helpful so that you know which thing you're doing in the cycle. I even myself will get a little bit mixed up between deep breathing and pursed breathing, but you can spend as much or as little time in each phase as you feel is effective for yourself. The next thing is autogenic drainage. So autogenic drainage, different from postural drainage, is a breathing technique where you start at very shallow, low breaths and you work your way up to bigger breaths at a higher breathing capacity. So if you take a deep breath in and blow all the way out, like you do in your PFT, all the way down, 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 then you're going to take little breaths in, out, in, out, in, out. Then you could take a little bit bigger a breath, in, out, in, out, in, out, and you work your way all the way until your lungs are totally full and you're doing little exhalations from that totally full position. Now, remember when I talked about postural drainage and how your airways are this tree and have all these branches? What this breathing technique is doing, and trust me, it's not an easy one and it takes some practice, is it is collecting mucus from the outermost branches into the innermost branches, from the tiny, tiny branches to the bigger trunks of the tree. So when you take the deep breath in and blow all the way out and you're doing those little breaths almost at your exhalation, you're unsticking the mucus from the farthest out airways. As you're getting bigger and bigger, you're collecting mucus into the middle airways. And then once you get to that total capacity and the small exhalations, you're evacuating mucus from the largest airways. This one definitely takes practice, but I promise you it is worth your time and effort. And again, breathing techniques can go wherever you are. So it is a good one when you're traveling, when you're commuting, because it just takes a little bit of attention to the details of what you're doing, but you can get big bits of mucus up in the middle of your day. So oscillating positive pressure, this is not something that is tremendously new, but in some clinics, they don't necessarily always have these recommendations for you. The two main devices that are recommended across cystic fibrosis centers and NTM centers are the Acapella and the Aerobica, made by different manufacturers. You can find some of these in local pharmacies. A lot of people find them more readily online. But the whole point of the oscillating positive pressure devices are two principles. The first is positive pressure. There's a dial on the back of the green Acapella. Now it's kind of a turquoisey. It's not so green anymore. And the Aerobica, it's a dial on the front. That is the resistance that puts pressure back in the lungs so that you can get air behind your mucus. The oscillations are the obvious part. As you blow into the device, it shears the airways. It has these little flappers that go back and forth to help break up mucus within the airways. These devices were made because things like clapping on the chest or wearing a vest weren't always something that people could do. They are less expensive, but they do require some maintenance and cleaning to make sure that you do not breathe in anything that you blew out into them. Also, I oftentimes, when people have an infection, I only recommend that they blow out into the device. And that they're cleaning it properly, as not, you don't want to breathe anything in that you already got out, right? The whole point of your airway clearance is to help keep you healthy. For the breathing technique for these modalities, it is your huff cough. It's your deep breath in, hold for 3 seconds, blow all the way out. When folks are starting these devices, I recommend that you do so in the seated position because taking lots of deep breaths can make you lightheaded. But once you get the hang of it, it is something that you could be going around your morning, blowing into your device, and doing other things as you're getting your day started. A lot of folks come to me and say, I went to pulmonary rehab, or I went to a different doctor's appointment, and they say I can put my nebulizers in line with my PEP device. I'm a little cringy about that. I'm not opposed to it, but I think there are certain cases where it is important to do your nebulized medications before you do your oscillations because you want to make sure your medications are in there and effective when you do your breathing techniques. But I do understand that you are busy people and that sometimes you need to combine things in order to get your day started and make sure that you got all of your therapy done. Of note, when it comes to nebulizers and our oscillatory PEP devices, we want to make sure that they're super clean and that we don't have any of our bacteria growing in our devices. So make sure that you're cleaning them properly. A lot of the data that comes on infections that come from our devices actually come from nebulizers themselves. So you really just want to make sure that you're thorough. Also of note, I put some arrows in here. There is a difference where you put your nebulizer depending upon the device that you're using. With an acapella, it's recommended that it be at the patient interface. With an aerobica, the company made a nebulizer that works with the aerobica and it can be put on the back because there's a one-way valve system within it. That also is a breath actuated nebulizer. So
good, thanks.
You blow out into the device. So the vest. So some people will come to me and say, I don't know why my doctor didn't just recommend that I have a vest. Or I hear that vest works really well for some people and not well for others. And just like I've been saying with your plan being customized to you, the vest was originally conceived of out of the cystic fibrosis population, which had a lot of kids who needed to have percussion done on their chest, and parents did not have the time to be positioning them all sorts of different ways and trying to corral a toddler and doing clapping on their chest and postural drainage. So the vest was conceived out of the idea to wrap something around the chest and be able to percuss on it. But once it was made, it was realized that all of the lobes of the lungs are being addressed and all of the areas are getting percussion at the same time. And then also we can do different programs of frequencies and times that we could program into this machine, and we could have better consistency with vest therapy. Also, it's something that could be put on a regimen and it could be documented how much time we spend on a vest. Hospitals loved vests because we just plug you in and have it percuss. And we knew we were giving consistent therapy. So the vest is really great for that consistency and that programmability. It also can give you independence as a patient to be able to, you don't need that clapping. Maybe you don't need to blow into a device and the vest can be effective for you. But it's important to know that it can be time consuming. It can be expensive depending upon what your diagnosis is and if you're an eligible candidate for it. Sometimes you have to have, they say the words tried and failed, which means you tried something else and it didn't fix you. So that your doctors may need to provide documentation. And also the flow inflating vests are something that are very stationary, and that doesn't work for everybody. There are vests that are available. The picture of the one that is there is called the Monarch. It does provide some independence where you can walk around with the device, but it weighs 15 pounds. It's like wearing a weighted vest. So it doesn't work for everybody. We do have people try it on in clinic, and some people are like, no go, I'd much rather wear the lighter device. And then there's others who are like, nope, this is what I need. I don't want to be tethered to something. I need to walk around. This is going to work for me. But an important thing to say is when you do vest therapy, it doesn't matter how much you shake your lungs, how much you shake the jar, if you don't do things to get things up and out. So it's became very common in certain age populations and in people who had chronic disease, that folks would put themselves on their vest and completely tune out, and then would come to clinic and say, why am I not better? If you shake the jar and you don't empty it, if you shake the jar and you don't do the airway clearance and the breathing to get stuff out, it's just going to settle right back down. So consistency is great with the vest, but we need to make sure that we're active participants in our airway clearance. And then what about these new devices out there? A lot of you have heard about Valera and Byways. Valera is not a new concept. It used to be called Medineb in the hospital. So what it is it's a positive pressure device, so similar to the acapellas and aerobicas, but it actually is pushing the positive pressure in, and then provides some percussion on the inside, active percussion done by the machine. It is programmable, and certain medications like your bronchodilator and your hypercell can be piped into the device. I mean, I think it's great. It is something that ever since I was in respiratory school has never really taken off. They're expensive. They're difficult to clean. And that's something I have a concern about in the NTM community is I want to provide you with resources that are slam dunks, right? I don't want to give you something that could potentially be a source to make you sick. So the Valera has corrugated tubing and a nebulizer. There's only bits of it that you can properly clean. You need to hang it in order to dry it. And the manufacturer has not given solid recommendations for how you can clean the device without compromising the integrity of the plastics. So if you feel confident in your cleaning techniques, it may be a good solution for you, but I just want to always be cautious when it comes to your own bacteria or NTM, or even waterborne bacteria that you use, that's in your regular water system getting into your devices. The Byways device is a new and up and coming, which I'm excited about, mostly because it's a competitor to Valera, and I hope it drives the price down for all of you, that there's somebody else out there. And I hope it provides more access for you. But both of these devices, they require a mouth or a face seal. You really need to be participating in what you're doing. You do need to be stationary for it, and they are on the expensive side. When we make recommendations for you, we don't want to cause you financial burden. Something that is exciting and up and coming is Byways the vendor is doing some trials coming up at home therapy. So they're working with some academic medical centers and also some private pulmonary offices to see if they can get some trials off the ground for home FDA clearance of the Byways device. What they're looking at primarily in these studies is not necessarily like mucus production or decreased in development of disease, but what they're looking at is this something that is easy to do for you at home? Is it something that helps decrease your treatment burden? Are you feeling generally better using the device? So those things are exciting and up and coming. They are a bit tough to get these types of trials in large academic medical centers because we have a lot of checks and balances when it comes to trials. But I'm just excited that somebody in the airway clearance world is giving some competition to others to give you guys some good devices. So I love to talk about respiratory hygiene when it comes to cleaning. And there was a question, and I'm glad Debbie sent it to me, about cleaning devices and the detergents that we use for things like that. So every device should be cleaned, and then we're going to talk about sterilization in the next slide. But cleaning is really important because all of our inhaled medications are based in salt waters, and some of them also can be a little bit sticky and they can stick within our devices. I've always been a fan of Dawn dish detergent, and not just because of the cute little ducks that they clean, like when there's an oil spill and they clean off the animals with Dawn. But I think it's a really good product. It passes things like the Food and Drug Administration's uh, clearance when it comes to being totally antimicrobial. Um, Dawn dish detergent does not have things like moisturizers in it that can sort of put things into your nebulizer that you don't want there. There are off-brand versions of Dawn. I'm not telling you have to use absolutely use Dawn, but Dawn does provide a free and clear brand, which is doesn't have any perfumes or dyes, which is great for cleaning your devices. So you want to take your devices apart, whether that's the Acapella, the Aerobica, your nebulizers, and you want to clean them in warm soapy water. Scrub anything that's visible there, and then rinse in sterile water. Sterile water is not something that you necessarily need to purchase. How you make it sterile water is you put it in a pot and you boil it for 5 minutes. So it's not something that's any more expensive, just takes a little bit of time. And I always say to folks, please dry on a paper towel, not an actual towel, just because molds and bacteria can grow in towels themselves. And then also, we're headed back into cold and flu season. If you're wearing a mask and it is cloth, please make sure that you are cleaning those things as well, because you don't want to rebreathe, right? So make sure everything is clean, or wear paper masks and change them frequently. When it comes to sterilization, there are multiple methods of sterilization, but I will start by saying, when you open your package of your nebulizer, your Acapella, your Aerobica, you are to look at the manufacturer's recommendations for how they want it sterilized. You do not want to melt your device in a pot of boiling water or in a microwave or things like that. Just make sure if they say don't do something, don't do it. But there are two standard ways that we sterilize. The first are heated methods, so you can boil for 5 minutes. Your dishwasher is awesome at getting rid of debris, and also very high temperature, so that you are sterilizing. You can microwave in a microwave safe bowl. It needs to be completely submerged in water for 5 minutes. My only between this and Medela steam bags, which are used for breast pump supplies, that those are both microwave functions. The Medela steam bags, they tell you how many ounces of water to put in, you zip up, and that's also a 5-minute sterilization. But please, I caution you, not every microwave is created equal, and there can be hot spots. So you just want to make sure. Actually, a great way to tell if your microwave has hot spots is if you take a stick of butter, put it on a plate, stick it in the microwave. If there's a laser kind of hole in it, that's your hot spot. So, just if you're using your microwave, you're staying in an Airbnb, a great way to know if there's hot spots is the butter technique. Also, baby bottle sterilizers are a great tool. They're not terribly expensive, and they do take up some space on your countertop, but you can put all of your nebulizer, Acapellas, Aerobicas into the device to sterilize, and it has a standard cycle that's used for bottles normally. Cold methods, these include different chemicals. So the top two are isopropyl alcohol. You want to submerge your devices in alcohol for 5 minutes. Hydrogen peroxide is 30, so longer, so you need to remember. Bleach is a diluted mixture of 1 part bleach to 50 parts water. I can't do that kind of math on a regular basis, so it seems a bit difficult to me. For these 3 methods, a technique that is a trick that a patient taught me: don't put them in a bowl. Use a Ziploc bag. You don't need as much liquid to submerge things. I was like, genius, wonderful. UV light is another way. If you ever go to a tattoo parlor or nail salon, there are UV light techniques, but plastics do not wear well over time with UV light. That's why we don't use it in the PFT lab. It actually would melt our plastics if we used them every day. So, so that is an option, but just make sure you look at your manufacturer of your nebulizer. We do not recommend vinegar. I know that's very popular for a lot of folks as a cleaning solution, but we do not recommend vinegar in NTM because it is not strong enough to get rid of your particular bacteria. So you can clean surfaces with it, but just not your nebulizers. And then mesh nebulizers. So mesh nebulizers are always a hot topic. Luckily, there are some new ones that are out there that you can mostly purchase online. You can use a mouthpiece or mask, but they are a little bit problematic in their cleaning in that you cannot put chemicals in them. And of course, you can't put them into a microwave or boil them or things. They have electronics in them. So you don't want to damage your device, especially after you make a purchase. So what they recommend in mesh nebulizers is that you empty any residual volume of liquid out of the nebulizer and you use 2 to 3 mLs or cc's of sterile water into the cup and you nebulize it for the 1 to 2 minutes that it takes until it's totally dry. Remember, sterile water is something you can make by just boiling it for 5 minutes, so hopefully it's no real burden to you. And then you want to store it in a clean and dry container, and also that paper towel technique so that it dries open. Something that is important to note too, so like while we're cleaning and sterilizing, we also, in the cleaning of the nebulizer, whether it's a mesh nebulizer or regular, you're making it more efficient and you're keeping it from getting clogged. Mesh is very easy to clog. So this is something you're going to want to do. If you can rinse them out after every use with the sterile water, that will increase the life of your mesh nebulizer. But even just doing it once a day can really make a difference. Salt water causes things to corrode. We see what happens to boats. So we want to make sure that we keep our equipment functioning. And then this was something that was very exciting. So in the hospital world, we often work with equipment that is not available to people at home. And for a long time, patients have been coming to me about mesh nebulizers, and I haven't been terribly enthusiastic about it because the home devices just aren't as good as the ones we use in the hospital. So this is a company called Aerogen, and I have been using Aerogen for probably 15 years, and it's a nebulizer that we commonly use for really complicated drugs when in line with a mechanical ventilator in the hospital. That's the way it kind of started off. They're pretty expensive. It did require, it's called a controller, which is basically like a button that powers the device. The reason we use it in the hospital is because we can use it continuously or in a 30-minute mode. And then we can pipe it in line with a ventilator and deliver medication all the way through the ventilator circuit to the patient. So pretty awesome. It makes it pretty far with a really small particle size. And we noticed that patients did better when they were getting medications through this device. As the years have gone along, ventilator companies started selling these nebulizers with the ventilators themselves. And so it wasn't as much financial burden to the hospitals, but I kept thinking to myself, why isn't this available to patients at home? Like, can we ever do that? So this is something that is like breaking news. So it is available in Europe as a home nebulizer, and is like seconds away from FDA approval in the US. Now, while I say that, and I'm super excited that it's something that will be available to you, it's not necessarily something that, even if it becomes FDA approved, that your doctors will be able to write a prescription and be able to get for you. It may be something that you can buy commercially to start, and we gather evidence as to how we can get it covered in the home setting from our clinic support standpoint. There are some limitations to the medications that you can use in it. So that would be a discussion with your provider. Can I take this medication with the Aerogen? But I already know, because I've been doing it as long as I have, bronchodilators and hypertonic saline go through this device beautifully. It is very easy to clean. It's same as the other mesh nebulizers, sterile water nebulized, but we're finally starting to look at a real evidence-based mesh nebulizer that has been used in the hospital for a long time and hopefully will be available to patients in the US soon. And I mean like in the next couple of months soon. So so finally, Debbie, I have a nebulizer that I approve for you, or at least it gets my gold seal of approval when it does get released. But I am an operations manager. This is not an inexpensive nebulizer, and I buy them in bulk, right? So so just know there is a cost associated. So after I talk about all these airway clearance modalities and all the different things that are available, you know, where does it leave you as a patient? So you want to, you know, follow the evidence base and do the medication order, your bronchodilators, your salines, you know, get them done, and make sure that you also follow the evidence that nebulizers and our devices need to be cleaned and sterilized properly. But when it comes to the practice of breathing techniques and the different airway clearance devices, it's really worth trying different things and seeing what works for you. Every one of you is an individual, and every one of you is going to react a little bit differently to the different treatment plans. So I hope that listening to the different things that are available help to give you more tools in your toolbox to be able to use them as you see fit. You may come up with a plan for yourself that I do these things when I'm well and I add these things when I'm sick, or I do these things when I'm at home and I do different things when I travel. All of it are different techniques. We want you to live your life. We don't want you to be burdened by airway clearance. So take the information and what your care team recommends for you and help with the partnership of you as the patient and your provider to come up with a plan that helps to give you that consistency, because that's really where all the data lies. Is consistent airway clearance is what helps you to feel better and to helps you to clear your infection in the long run. So that's it for me. I will take questions in the comment section, and I hand back to whoever wants to take the next.
Thank you. I think Dr. Kurtz is up next.
Very good. All right. So Sebastian Kurtz, thank you for the nice introduction. I joined the Yale team about 1.5 years ago, and I'm very happy to have the opportunity now to speak to you about bronchiectasis and to give you a brief update. This is probably very basic for the audience. However, thinking about the diagnosis, it's usually a combination of symptoms, imaging, and then we do supplemental testing to try to figure out why you have bronchiectasis. Oh, this goes on autopilot, so I have to be quick. All right, the diagnosis. That may be the list of symptoms you're going to write down for your doctor's visit. I have a cough, congestion, short of breath, fatigue, fevers, and weight loss. And your doctor may ask you a couple of other things. Do you have any sinus disease, any reflux in the mix? How was it when you were growing up? Did you have any childhood disease, asthma, COPD, smoking, any other medical disease, family history? And then we will ask further questions about the time course, symptom burden, dynamics. Well, this is too quick. Wait a second here. Don't do it timed. I think this is better, I hope. We'll ask a question about what's the time course, what's your symptom burden, what's the dynamics actually? Is there any change over the weeks, over the month? How many exacerbations have there been? And which treatment has been received and to which effect? The diagnosis, however, really hinges on the imaging. And here I have two examples. On the left, you see a classic chest X-ray. And on the right, you see one cut of a CAT scan. And you may you may notice that the degree of bronchiectasis on your chest X-ray it can be much underappreciated compared to the CAT scan. So here you have some changes here at the hot borders, but when you look at the CAT scan, you have big cystic changes in your airways. Secondly, looking at the distribution within the lungs, which zone are affected, can actually give a hint on what the potential diagnosis. Here on the left is an example of a patient who has upper lobe predominant disease, which is due to cystic fibrosis. And on the right, you have a patient with lower lobe disease. I only have a cut here on a CAT scan caused by ulcerative colitis. So different diseases do have different manifestations looking at the imaging. Further testing. A lot of is done by lab work. Looking at the guidelines, we often start off with a first-tier testing, which can be done in your primary care office. Blood count, immunoglobulins to see if there's any signs of antibody deficiency, checking for allergic immunity against aspergillus that can be sitting in the airways, and spirometry, see what the lung functions are. Second line is what most patients gonna get, some sort of an autoimmune workup, ANA testing, rheumatoid factors, and things like that. Checking out for sinuses, see if there's any sinus disease, reflux testing, alpha-1 antitrypsin, which is a protein. The lack of the protein often associated with emphysema and COPD, but we do see it also in bronchiectasis. Maybe consideration for sweat chloride testing for cystic fibrosis, and for sure we're going to get sputum cultures, also checking for mycobacteria. And then there are third-tier testings, looking at genetic screening for genes in the body that can be associated with bronchiectasis. Most probably a CFTR, that is a gene that is altered in patients who have cystic fibrosis. Sometimes we get surprised about an HIV diagnosis. IgG can be subclassified. Sometimes there's subtype where you see low levels. We may check if you have what we call lazy antibodies, which means a insufficient antibody response to certain antigens. We do that by a vaccine challenge. And there are several ways to diagnose ciliary dysmotility syndromes, ciliary dyskinesia, which often takes a little bit more of a complex testing. And often, actually more often than not, we still have to tell you we do not know exactly what the problem is. We call it idiopathic, and we do acknowledge that this can be frustrating for the physician and for the patient alike. And it's always a question, how far should we go in terms of trying to find more probably subtle abnormalities that can account for this syndrome? This is from a review done a couple of years ago, but it still holds true that we think in the spectrum of the idiopathic bronchiectasis, there are probably variances in immunity, in the composition of the connective tissue that makes the walls of our airways, in the function of the mucus production and the mucus escalator, that we are not capturing with standard testing that account for the syndrome. Maybe a more helpful view on that is to look at the biologic drivers, what's causing the disease. One of them we heard a lot about is about the impaired mucociliary clearance, infection, and then what we more and more recognize, probably even independent of infection, that inflammation in the airways plays a significant role. This can translate into what we call treatable traits. Airway clearance, we heard a lot about it. I'll just let it stand like this. Infections, think about antibiotics, think about inhaled antibiotics that can keep the bacterial burden down, and inflammation, on its own. Now, the latest part has gotten more attention now since we're seeing more and more ways to modulate that inflammation to modify the course of the disease. So let's talk a little bit more about how we can modify that inflammatory reaction. One of the ways is actually fairly old macrolide therapy, azithromycin. We always think, firstly, this is an antibiotic, which it is, but it also has direct effects on how the immune system is being modulated and how the inflammation is being reduced. So we know it does reduce exacerbations. It can improve symptom burden. It has a problem which can cause antibiotic resistance. We are aware of the problem with NTMs, where macrolides are one of the mainstays of therapies. You don't want to lose it by exposing a patient who has undiagnosed NTM disease by putting them on macrolide therapy. And in some instances, we do see hearing loss in long-term use. The newest kid on the block is are the DPP1 inhibitors, the neutrophil elastase inhibitors. Essentially, what they do is they take out the ammunition of the neutrophils, so that the neutrophils that are being produced are not as toxic to their surroundings. That happens as the neutrophils are being made in the bone marrow. The one drug that recently came out, I'm sure you heard quite a bit about it already by press releases, is brensocatib. And there's a second agent in clinical trials right now, which has a similar mode of action. A third aspect here is looking at eosinophilic inflammation. This is a part of your immune system that deals with parasites, so it's not completely useless, but it does cause problems in terms of asthma. We also know, like, in 20% of people with COPD, it plays a role. And now we also see in about 20% of people with bronchiectasis that eosinophilic inflammation does play a role in the symptoms and exacerbations and so forth. So there is interest in using drugs that have been originally designed to treat asthma in bronchiectasis. Benralizumab is one of them, has a long track record now in asthma. And another one that is being actively studied is itepekimab, which is an IL-33 blocker. Again, these are cytokines that all play part in this inflammatory cascade in this allergic type of inflammation. So I briefly gonna have a closer look at those three drugs here. So this was a trial on brensocatib that was published this year in one of the prominent journals, the New England Journal. And what they found is that over a period of a year, there was a significant reduction in exacerbation in people with bronchiectasis. There was some slowing down in lung function decline at a higher dose, but there were no significant difference in symptom scores. There were some skin and gingival side effects, and based on that study, it just recently got FDA approval. So we are all very keen on seeing how this is gonna play out with our patients in the real world. There is a second drug, which I already had mentioned, that works on the similar pathway, that underwent preclinical and early clinical trials, and that's also being studied right now. There are ongoing clinical trials on this one. Here, the activity study is a phase 3 study for this drug. And on the eosinophilic side, the itepekimab trial, looking at people with bronchiectasis that have this eosinophilic phenotype, again, about 20% of the whole population. And this just has completed enrollment. So we're very excited to see potential results for these drugs. So if you think about looking at this biology, it may at the end not be as important to really pin down what is exactly caused, why do you have the disease, but thinking about these biologics, what we hope for is that we're gonna be able to change the trajectory of the disease, to stabilize the disease, have less exacerbations, and to really boost these protective factors. So with that, I'm gonna close. Take home points. It is bronchiectasis is a syndrome. 50%. We do not have a final diagnosis to offer. The 3 I's, impaired mucociliary clearance, infection, inflammation, gives us potential treatable traits. And the new thing that is being very exciting for all of us is focus on modifying that inflammation. Brensocatib got the FDA approved. Other trials are ongoing with activity for the other component and itepekimab, which we're waiting results. All right, with that, I'm going to close. Thank you.
Okay. Dr. Lozier is up now.
All right, can you guys see that?
Yes.
Okay. So I'm going to talk today a little bit about living with NTM lung disease and what's new in the care and treatment of NTM pulmonary disease. So just quickly, so I'm going to do a very brief background on the epidemiology and disease burden of NTM. I'm going to just outline what the diagnostic criteria is in case people are wondering kind of why people get a diagnosis and some people do not, depending on the quantity of or the amount of sputum cultures. I'm going to discuss some of the advances in diagnostics and then just a bit of updates in the clinical management and the emerging therapies in the pipeline. So just quickly, is like NTM are a group of bacteria that are often environmental. It's like there's a lot of different species. It's like well over 200 that are currently described, and they're typically classified into rapid growers or slow growers. Perhaps the most common that most individuals might be familiar with are Mycobacterium avium complex, which is a complex of bacteria. So there's several different subspecies within that, and this just outlines avium, intracellular, and chimera. And then is it the rapid growers, which amongst the rapid growers, the most common is Mycobacterium abscessus with the subspecies outlined here as well. And what that just distinguishes between slow and fast growers is really just the time that it takes to grow or show up on a culture, with the rapid growers typically presenting as positives much faster than the slow growers. So if we look at the epidemiologic trends within the United States, we do see that there is a rising incidence and prevalence of NTM over time. And this is just a graph that looks between 2008 to 2015 with the incidence on the top and prevalence on the bottom. And we can see that over the period of about 7 years, there was an increase in the rates of NTM pulmonary disease. And that's really outlined by the increasing amount of dark blue on this graph. And then on the right side of this slide, we can see that amongst individuals who are over the age of 65, the rates were the highest. And then there was also a higher rates in female sex as well. And then within the United States, the geographic distribution of NTM species really does show that there's a higher number of Mycobacterium avium or MAC being present, with about 60 to 80% based off this figure here on the right, showing as yellow, that's all MAC. Or as the actual complex itself, up to about 80% of those NTM isolates in the United States. And then other species include abscessus, which is the green, and then all other species are kind of listed in the blue. So really, MAC is the most common within the United States, and that's why I'll spend the majority of my time within the treatments, focusing on what are the common treatments towards that. So if we look at why some individuals get NTM and others do not, it really is a complex interplay between the host, which is the individual themselves, their potential exposures, which are kind of the environmental reservoirs that the NTM could live in, and then the NTM species itself. So I'd mentioned about rapid growers sometimes being associated as the more aggressive species. So depending on kind of what species they are, what they interact with, and this whole interplay between this triad, we do see that some individuals may acquire it versus somebody in their same household may not. And this complex interplay has really morphed into this description of the NTM exposome, which just kind of further elaborates on specific external and general external environments that may or may not be modifiable for the individual who is exposed. So things like shower heads and gardening exposure. But then there's also mineral content within the soils and water management in the municipal regions that people may live in. And so that interplay kind of interacts between the host, whether it's the sex, the genetic susceptibility, or if they have predispositions towards bronchiectasis, and their age. And that can all play together to see whether or not somebody actually develops true NTM pulmonary disease. And as I mentioned, there's a lot of different risk factors similar to bronchiectasis, as Dr. Kurtz just outlined. A lot of the factors that contribute to whether or not somebody gets NTM pulmonary disease often involves whether or not they have pre-existing structural lung disease. And it's often this kind of analogy of the straw that broke the camel's back, where oftentimes people may get NTM pulmonary disease first and develop structural lung disease, or they may have structural lung disease and then get NTM afterwards because they were a great host for this bacteria to live with. But that could be because of any genetic or hereditary mutations that may have predisposed them to developing bronchiectasis, or conversely, acquired factors that may have predisposed them to developing bronchiectasis or immunodeficiencies. So things like kind of chronic immunosuppressants or corticosteroids that may have increased their risks as well. Perhaps the most classic description of host susceptible phenotypes or descriptions of patients who get NTM is the description of Lady Windermere. So this was an older, typically characterized as an older female who was thin in stature, may have pectus deformities on the sternum, or some scoliosis in the spine, and then perhaps a mitral valve prolapse, if the diagnosis had already occurred. And then the classic radiographic imaging that goes along with that is typically this bronchiectasis in the right middle lobe or the lingula. And it's typically just some mild bronchiectasis or tree and bud opacities that are noted on the imaging. Conversely, in men, as I mentioned, it's typically an older patient population of greater than 65, but the classic description is a fibrocavitary imaging that's thought to be more progressive, as it can sometimes be associated with underlying COPD as well. So the ATS, or the American Thoracic Society, and the IDSA have a rubric that clinicians will follow to diagnose NTM pulmonary disease. And this requires 3 different categories. One is pulmonary or systemic symptoms, which typically will involve classic symptoms of fatigue, productive cough, shortness of breath, night sweats, weight loss. Many of the questions that you'll have your providers that they may ask you during each visit when you come to see them. But then you need to have radiographic findings as well on either a chest X-ray or more often a CT scan of the chest, just as it tends to give a lot more detail to characterize the imaging. And that's typically characterized as either nodular bronchiectatic or cavitary. And then the last part of that diagnosis, to obtain the diagnosis, microbiologic results are needed. So I often have patients come and ask about an imaging finding that says they have tree and bud opacities, and this could be suggestive of mycobacterial infection or NTM. But really it does require a microbiologic diagnosis. And what that means is generally 2 positive AFB samples that are either coughed up or expectorated, or 1 bronchoscopically obtained sample. So that is typically a bronchoalveolar lavage, or it could include a lung biopsy with positive histologic features. And then kind of within that diagnostic rubric, we have the radiographic findings. And what these mean for those of us who are not reviewing chest CTs every day, are nodular bronchiectatic typically is the milder form of disease, is where you see just enlarged airways scattered throughout the lungs, along with some areas of mucus plugging. Or fibrocavitary is often where you'll see a cavity in the lungs that could be thick-walled and inflamed, and that's often suggestive of a more aggressive kind of form of NTM pulmonary disease, or more at risk of progression. So traditional diagnostics really do rely on culture-based assays, and that really remains the gold standard for identifying NTM pulmonary disease. But I'm sure many of you have realized that these cultures take a really long time. We're frequently quoting anywhere from 4 to 8 weeks to get final results for some of the cultures. And depending on the day or the sputum specimen, there is a high rate of false negatives. So really, novel diagnostics are needed, and just to help aid in more rapid identification of these infections. And there are some that are in the pipeline that I'm just going to highlight here, as most of them are not really ready for prime time use, but they are highly sensitive and specific, and may have utility in both monitoring treatment options along with the response to therapy. So first off is metagenomics, which is includes nucleic acid amplification tests. These are just a lot of kind of really is a kind of rapid test, where a sample can be obtained and essentially sent off for processing and sequencing, and really rapid turnaround to try to help get specific identifications of species and subspecies. These are typically quite expensive to be able to run, so they're not readily available in all institutions, but can be really helpful when it comes down to trying to get a positive culture result fully identified over to identify the subspecies of the bacteria there. Also, recent developments are looking at cell-free DNA, which has been a relatively popular diagnostic use in multiple disease states at this time point, whether it's cancer diagnostics or other disease states. But cell-free DNA essentially is a blood test, where they check for circulating levels of DNA that are present. And in this study that was published last year, they were looking specifically at MAC cell-free DNA, and they saw that levels of MAC cell-free DNA actually correlated to true disease states. So if they saw that somebody had already had diagnosis with cultures, they were able to correlate that elevated cell-free DNA levels were present in those who had a formal diagnosis of NTM pulmonary disease. And they saw that in those patients who were initiated on treatment, that as they tracked the cell-free DNA levels, those actually started to decrease as treatment went on. And perhaps the newest diagnostic that's been receiving additional publications is the glycopeptidolipid core IgA antibody. So again, another blood test that could be helpful in screening patients for NTM pulmonary disease. They looked at patients who had bronchiectasis without any NTM infection, which is present on the left here. And then they saw that whether or not the patient had a one-time culture that was positive for an NTM species versus those who had multiple cultures that gave them a true diagnosis of NTM pulmonary disease, that the levels did go up. And it was the same as whether or not somebody had a MAC isolation and whether or not they had true MAC pulmonary disease as well. So this is something that, like I said, is not ready for prime time use, but might be something that's helpful in guiding therapies as additional studies go on. One of the questions that's really frequent in clinic is kind of when to decide on the initial treatment of MAC or NTM pulmonary disease. We know that the treatment burden is significant with the amount of antibiotics and potential adverse side effects from them. So we're often kind of left balancing the watchful waiting versus initiating treatment. And in some individuals with few symptoms and as smear negative or relatively mild findings for risks of progression, it can sometimes be decided to obtain watchful waiting in that person, depending on what their symptom burden is. But in those who have many symptoms or have findings that are suggestive of a higher risk for progressive disease, such as cavities, or if their cultures are smear or stain positive, or a more aggressive form of NTM that was isolated, treatment may be initiated earlier rather than considering any potential watchful waiting. And one thing to consider is that the reasons to treat NTM really is that it's associated with decreased quality of life and increased comorbidities and mortality as it can progress over time. And so it's really trying to balance the weight of these treatments with the risk of progression is a lot of the discussion that you should have with your providers if you're considering treatment. And really this is the most classic regimens that are outlined for NTM pulmonary disease, specifically for MAC. Abscesses is additional antibiotics on top of this most often, but nodular bronchiectatic can include a 3 times weekly regimen of a classic 3-drug regimen, which may be azithromycin, rifampin, or ethambutol as the most common agents. But then if somebody has more aggressive disease, such as cavitary disease, the addition of an IV agent such as amikacin may be added to this regimen as well. It's really important to monitor for adverse drug reactions, and there's not official guidelines as to how frequently monitoring should occur. So check with your providers on how frequently to obtain blood testing. But typically, as our practice is to obtain blood work every 1 to 2 months, depending on the stability of the lab work. Generally, we'll start as more frequently at the beginning, and then as things get stable, or we're closer to completing treatment, we may be able to space things out a little bit at that time. Vision and audiology assessments are important, given that some of these medications can have eye side effects along with hearing side effects. So typically an initial baseline set of testing should be obtained, and then depending on the results of that, follow-up testing should be every 3 to 6 months. And then other important monitoring aspects include EKG monitoring, and that's largely depending on the antibiotics being used, but medications such as azithromycin can have QTC prolongation, which just means that it could predispose you to risks of abnormal rhythms within your cardiac heartbeats. So this is just the most common side effects that are listed here, and I do outline amikacin as well, particularly in those who are on inhaled amikacin. The most common side effects really tend to be dysphonia or kind of hoarse voice, cough, and shortness of breath that can be specific to that nebulizer. But then the other side effects that are associated with amikacin can include the kidney or hearing abnormalities that can occur as well. I'm not going to delve into any great detail on this, but adjunct therapies are really important in NTM management. Marjorie already so eloquently outlined airway clearance, but then also minimizing risks associated with reflux or potential exposure-related injury, either from smoking or potentially recurrent exposure to high-burden NTM environments. And then staying well, maintaining adequate nutrition, hydration, and aerobic activity to maintain muscle mass and normal BMI all remain really important to help prevent progression as well. So then once somebody's on treatment, we as like are frequently looking to see how long treatment is going to last. Guideline-based therapy is 12 months from first negative cultures. But what happens if cultures stay positive and as it don't convert to negative? So it's like you're still having positive MAC or positive abscesses on your cultures. And typically at 6 months by the ATS guidelines is really where we consider that to be a treatment failure or refractory NTM. And that can be from any number of reasons, as specifically medication adherence, or side effects making it difficult to tolerate the full course, whether or not somebody might have developed resistance in their NTM, or potentially is whether or not they're able to clear their secretions, or performing routine airway clearance could be another potential factor that could contribute to lack of culture conversion. So when this happens, our next step is often to reach for inhaled liposomal amikacin. And this was the newest addition to the guidelines that came out in 2020, looking at, at 6 months adding on inhaled amikacin. And that was successful at helping an additional portion of patients achieve culture conversion generally around month 4 after adding that on. So this is now in the guidelines and should be part of the next steps in therapy. We often get questions as to whether or not surgery should be considered as an NTM patient. And this really does require careful selection of the patient and what their underlying lung status is, whether or not their lung function is in a safe range, and whether or not the disease is relatively localized. There are low rates of mortality associated with it, but obviously it is a large surgery, so there are high rates of morbidity or kind of potential complications that could occur after this, and morbidity can be associated with the duration of hospitalization afterwards. It is associated with a high amount of culture conversion. About 93% of patients can postoperatively may actually be able to achieve culture conversion, and this was in a recent study in CHEST in 2023. So that is something that you could consider with your healthcare providers. And it may ultimately help decrease the recurrence rate as well, as depending on the area of the lung that was able to be resected. And then just lastly, I want to quickly just highlight some treatments that are on the horizon. As I know Dr. Kurtz already outlined bronchiectasis and all the exciting events that are happening there. But there are treatments in development for NTM as well. Given kind of how hard these treatments are already to tolerate, it is really important that we have some additional medications or therapies in the pipeline as well. So this is just a slide outlining some of the treatments that have been in development over the past handful of years, and current clinical trials that are ongoing as well. And I'm just going to outline a couple of these at this time point. So the ARISE study, which some of you might be familiar with, or the ARISE or ENCORE study, was inhaled liposomal amikacin being used as first-line therapy for MAC pulmonary disease. So rather than waiting until the 6 months to say that you were refractory, potentially having it on at the first treatment phase, with addition of azithromycin and ethambutol, rather than rifampin. And the prelim studies that were released in 2024, show that there was a trend towards culture conversion at month 7. This was not the primary endpoint of the study, so that is going to be released once the ENCORE study is released, I suspect. But the key outputs of this study were really the quality of life metrics for this treatment protocol. And they saw that those who were started on inhaled liposomal amikacin did have improvements in quality of life scores, with that being part of the frontline therapies. There's a lot of discussion surrounding whether or not clofazimine, which is another antibiotic, could potentially be included into treatment regimens. And this was a study that substituted clofazimine in place of rifampin or rifampicin adjuncts. And what it was able to show was that a regimen containing clofazimine, ethambutol, and macrolides showed similar efficacy and could be considered for treatment of MAC pulmonary disease. This is currently not in treatment guidelines, but it is something that has been an ongoing topic of research, as well as of potentially having clofazimine containing regimens. And this kind of relates over to the nebulized clofazimine study. And so the current studies that are ongoing globally include the ICON-1 study, which is looking at the use of nebulized clofazimine in refractory MAC patients, so those who don't convert at 6 months. This may be a trial that patients may want to consider as if they're concerned about potentially amikacin, or if they did not tolerate inhaled amikacin before. And then some novel therapies that have been in studies recently have included inhaled nitric oxide, which was added into those with refractory NTM as a potential bacterial static agent, and it was found that those patients who had that added to their treatment were able to tolerate it, one, from a safety profile, and that they were able to prevent progression, and some were able to achieve culture conversion. Mycobacterial phage, which is virus that infect the mycobacteria, can be another potential treatment adjunct, which I think the NTM support groups have had recent talks on as well. And then GM-CSF is the other treatment modality that has been utilized as an immunomodulatory effect as well for patients with NTM. And this is a study that just looked at the use of bacteriophage in disseminated mycobacterial infections, and really looking at how phage could effectively reduce the burden of Mycobacterium abscessus in this particular patient, where before treatment, you can see here on the scan, there's a lot more kind of bright colored activity here. And then after treatment, that activity or the amount of Mycobacterium was decreased, which you can also see here in the black and white images as well, which is before treatment on the left and post-treatment on the right. So just to conclude, the global incidence and prevalence of NTM are increasing, and it's really important for both patients and providers to be able to identify patient risk factors for acquiring NTM pulmonary disease and to try to help identify those who are at risk of progression. And this will help with prompt diagnosis to help prevent treatment delays. And then also to be aware that there are adjunctive and emerging therapies that are in existence and on the horizon of development for NTM pulmonary disease. So thank you, everybody.
Okay, thank you very much. So I did drop into the chat a link to the conference that's taking place this Saturday. National Jewish Health is having their patient conference for NTM and bronchiectasis. They are going to cover a lot of topics, so there are some things that may not have been covered here that you might have questions about, and that would be a good place to address those things. So I think we have a final few questions just to go through.
Amy?
Yes.
If I can just ask, are the participants able to see the chat?
Yes, yes, I dropped it into the chat and it's addressed to everybody. So everybody should be able to see the chat.
Okay, thank you.
I do want to also mention, somebody's asking about the sterilization methods in killing NTM. One of the things about, cleaning our equipment and everything, there hasn't been a lot of science in the past. There haven't been a lot of studies done. I do know that Jennifer Honda has been doing a lot of research on this in her lab, using various methods and looking at airway clearance devices. That's going to be very useful in the future. We'll have some more clarity, I think, on that. So I think that's probably another good reason for you guys to tune in on Saturday to the National Jewish Health conference. So hopefully that that helps. So we have a couple of additional questions. This one might be for, well, for all of the doctors online. So somebody's asking about fluid ounces of liquid per hour due to GERD and a hiatal hernia, and it creates a dilemma. I think that's probably something that also you can learn more about when Michelle McDonald speaks on Saturday. But I don't know if any of the doctors would like to address, any of that now, just talking about, the need to stay hydrated and balancing that with, other concerns like GERD.
So I'll make a start. I think the point is very valid. If you think about reflux and hiatal hernia, it's like having a bottle where the lid is not tight. So when the bottle is empty and you lay it down on the table, nothing's going to spill out. But if the bottle is full, there's a risk of things spilling out. So I think these are rules of thumb. We try to keep the stomach as empty as possible, but incorporating that into your daily routine. Yes, people are thirsty. People, like to drink. So most importantly, I think, is to have your stomach as empty as possible before you lie down, for example. Or if you have a vest, before you do airway clearance, or if you tend to be active before you do aerobic activity, before you bend down and things like that. This is where these spillover events are much more likely to happen. So, I think when you're sitting relaxed in a chair, you are your risk is less to aspirate. So you may be able to have a little bit more fluid at that time, but before you lie down, changing position before activity, I think trying to keep it at a minimum is well advised.
Okay, thank you. All right, thank you so much. I think we've gone through all the questions actually that were in the Q&A. We are at an hour and 45 minutes for this webinar. That might be a new record for us. So thank you very much to all of our panelists and our guest speakers today for taking the time and for being so patient and for going through so many questions. We really appreciate it. This has been a wonderful event. We love having you back every year. We look forward to doing this again next year. Thank you all so much again for coming, and everybody have a wonderful afternoon, evening, morning, wherever you are in the world. And thank you so much for joining us. This has been recorded, and as we mentioned earlier, we will put the link up online so that if you were unable to attend part of it, if you missed something and you wanted to catch that again, you'll have the opportunity to do that. So the recording will be up in a couple of weeks, and we will get that out to you. Thank you again, everyone. We really appreciate it.
You.
Thank you.
Thank
Thanks,
you.
everyone.
Thank you.
Bye-bye.